only exemplar we'll cover from this chapter is going to be traumatic brain injury, or TBI, okay? When you think about a patient that has a traumatic brain injury, what comes to mind? Concussion. Some type of concussion, okay? What else? Maybe a car accident. We see that a lot. Especially patients that don't wear seatbelts. They can tend to get bumped around a little bit more in car wrecks. Absolutely. Diving into a pool. I had a young lady recently, like right before we came back from the summer, who was in a lake. And you know, in lakes you can't see the bottom of the lake. At least in a pool you can judge, you know, how far to go. But unfortunately, lakes are dark water and you can't see the bottom. So what she thought, the depth that she thought she had, she did not have. And when she went to dive in, she actually ended up with a head injury. She hit her head on a rock that was resting in that water. And fortunately, was able to go home that same day. But we know that all patients are not, not that fortunate. So, a traumatic brain injury is damage to the brain from external mechanical force. So something within the environment that leads to this patient having some extent of a brain injury. It is not caused by any neurodegenerative or congenital condition, which means that it's not age-related and it's not birth-related, okay? It's something that occurs later by an external or outside force. TBIs can lead to impairment in cognition. That's our ability to think. It can impair our mobility, which is our ability to move, our sensory perception, which is our ability to feel, touch, smell, and then also our psychosocial function. So sometimes we'll have patients that have traumatic brain injuries that aren't able to perform the way they did pre-injury. So they may have impulse control issues and such, okay? The injury can be direct or indirect. So if it's a direct injury, that just means that something hit that patient's head or the head hit against something. So it's going to be a direct blow to that patient's head. So that would be like my car wreck patient who hit the windshield or maybe the window itself. It could be my car wreck patient who's ejected out of the vehicle and hit the ground with their skull. This could be my football player who had a blow when they were playing a game or practicing. And an indirect is just a force applied to another part of the body that then leads to a brain injury, okay? So the skull or brain itself was not hit. Some other part of the body was injured, but it still had a rebound effect on the brain. So when I think about like the abdominal cavity and someone was to come up and punch you in the gut, what happens to all the organs in your belly? They shift and they move, they adjust to an extent to that injury, right? But what happens with the skull? So someone comes up to you and punches you in the skull or hits you in the head with a bat. What happens to the contents within the skull or the brain? They shift, but do they have a lot of room? Because what is the skull in adults? It's hard and it's rigid. Remember, in our babies, what do we have? We have soft spots in our babies, and they can adjust to an extent to any shifts within the contents of the skull. Adults don't have that ability to do that. Once those soft spots close, it's hard, it's rigid, and if you have any shifts within the brain, like as far as the volume, if it expands due to edema, if you have any increase in the blood volume or the CSF volume, there's no place for it to go except up against a wall, and that's going to be that skull, okay? So that's the reason that brain injuries are so difficult, is because the body has nowhere to shift that fluid production or that edema that occurs within the skull. So you have primary and secondary injuries. A primary injury just means that I'm noticing something at the time of injury. So I'm noticing the effects of the injury at the time of injury. They're pretty apparent when I get that patient. So it results from the physical stress or force within the tissue, and it can be focal or diffuse. So if I have a focal injury, what is that like? A specific area, it's an isolated area within the brain that has been injured. And on the opposite end of that, if I have a diffuse injury, what does that mean? It's many areas. So it's multiple areas that have been affected. Now, is one more severe than the other? Maybe, maybe not. It really depends on the extent, okay? So it really depends on the extent of the damage and how severe it is. The problem with diffuse injuries is they're usually not seen very quickly. They occur, but because they're so scattered, we don't always pick them up on our CTs and MRIs, okay? So if I have a focal injury, it's pretty apparent when we scan that patient. With diffuse, because there's many injuries that have spread out, a lot of times you're just not going to get that on that initial CT. So sometimes we'll have patients coming in, we'll scan the patient because they've had some type of injury, and they'll say they have a clear scan. Well, we'll still keep that patient to observe them because we know injuries can be more prominent later. It didn't mean they didn't occur at the time of injury. We just didn't have the evidence because all the shifts and swelling and such don't occur until later, okay? It can be open or closed. So if I have an open brain injury, what's happening with that patient? The skull is fractured, and I can see some extent of brain matter, okay? So the open injury, the skull is fractured, and I can see some extent or some amount of brain matter. Now, let's say if I have someone who's playing basketball, and they fell, they hit their head on the floor, and they have a laceration to the scalp. Is that considered open? That isn't, okay? Because the skin has been compromised, but the skull itself hasn't, okay? So an open injury is going to be where the skull itself is fractured or open. Sometimes we'll have patients that get stabbed in the head. That's going to give you an open injury, okay? Gunshots will give you open brain injuries, all right? And of course, if it's closed, the patient still has that injury. It's just no obvious blood or compromise in the skull when you look at that patient, okay? So open means that it has been penetrated, the skull itself has been penetrated, and closed means that there's still a brain injury without the penetration, okay? So if I have an open brain injury, in addition to all the other stuff and complications that we'll talk about, what else is that patient at risk for? Infection. All right. So it can be mild, moderate, or severe. And who's going to determine the severity of that patient's brain injury? The physician. Okay. So we'll gather some data, but they'll make that final decision because it's not based on one single thing. Now, if they come in with a stab wound to the head and the skull, that's pretty obvious, that's severe, okay? But otherwise, they'll have to gather several things. So what they'll look at is what happened, what kind of injury was it, what was the patient's Glasgow Coma Scale, or GCS, what were the results of your imaging scans, and the signs and symptoms that the patient presents with. So we'll look at what kind of injury it was, the patient's GCS, their CT or MRI images, and any signs and symptoms that the patient presents with. Once all that data is gathered, then the physician can make a decision about whether it's mild, moderate, or severe. What is a concussion? Okay. traumatic injury to the brain caused by a blow to the head, and will be considered mild, moderate, or severe. Mild. They're pretty common. This time of year, how do we get a lot of concussion patients? Football injuries. So football injuries this time of year, we see a lot of kids come in with concussions. So then we have secondary brain injury. And that's going to be any processes that occur after the initial injury and worsen or negatively influence the patient's outcome. So this is going to be something that we don't see when the patient initially presents to the healthcare facility. So secondary brain injuries are related to physiological, vascular, and biochemical changes that occur as a result of the injury, but they're not apparent at the time of the injury. They evolve over time, or they develop over time. So one thing that a patient can have is called post-concussion syndrome. So post-concussion syndrome. With this patient, they have ongoing complaints of headache, impaired cognition, and dizziness. So with post-concussion syndrome, they'll present with ongoing complaints of headache, impaired cognition, and dizziness. And what might that impaired cognition look like? What things may the patient complain of? Memory loss, sensitivity to light. They may have difficulty recalling events, difficulty remembering just simple things. But it's not severe impairment. It's just they'll notice like, oh, I went to go do something, I forgot what I was going to go do. Things like that. What is vertigo? Dizziness. It's an ongoing feeling of dizziness. So a lot of patients will get vertigo because of inner ear problems. But these patients get vertigo because of the injury itself. These symptoms will begin post-injury and can last months after the injury. So with vertigo, they have a feeling of dizziness or like they're spinning within the room. Another complication that we can have is chronic traumatic encephalopathy. So chronic traumatic encephalopathy, it is a degenerative and progressive disease. So it is a degenerative and progressive disease as the brain gets worse over time. So patients that have repetitive head injuries can develop CTE, and it's where the brain degenerates over a period of time. So a lot of times we'll see this like in our athletes, especially professional athletes, that they begin to have CTE. Boxers are likely to get CTE because they take so many punches during those events. If a patient develops CTE, they're going to be at increased risk for dementia, suicidal thoughts, and substance use. So those patients are at increased risk for dementia, suicidal thoughts, and substance abuse. And what they've noticed is that it causes neuropsychiatric changes that lead to those other conditions. So how could we diagnose a patient with CTE? Looking at their scans, clinical history, their clinical manifestations, but it can only be confirmed or ruled out with an autopsy, okay? So when they present, if you have someone who does boxing for a living and they present with some cognitive changes, that physician can diagnose them with CTE just based off scans, clinical manifestation, and history, but it can't be confirmed until they have an autopsy, okay? And unfortunately, once we have an autopsy, we're not coming back to get that diagnosis or have that confirmation of that diagnosis. Any questions so far? Additional problems that the patient can develop include hypotension and hypoxia. In these patients, when we look at hypotension, we're not necessarily looking at a systolic or diastolic. We're looking at their MAP, or their mean arterial pressure. So we're looking at their MAP, or their mean arterial pressure. So not necessarily looking at systolic or diastolic. We're looking at their mean arterial pressure. And anything less than 70 is going to be considered hypotension in these patients. To determine if this patient has hypoxia, we're going to look at their PaO2. So we're going to look at their PaO2. And anything less than 80 will be considered hypoxia. So if I have a patient with a brain injury and they have hypotension and hypoxia, what happens to that tissue? What happens to perfusion and circulation to that brain tissue? Clots could form, but what else? They don't get what they need. They don't get the blood flow and the O2 that they need. Their perfusion will decrease. So when that patient has hypotension and hypoxia, the perfusion to that brain tissue will decrease. Not maybe worsened by a clot that has formed, but overall that perfusion will not be what we need it to be. If a patient develops hypoxia, then it equals a poor prognosis for that patient. So if they develop hypoxia, then it can, or it will, equate to a poor prognosis in that patient. I'll come back to ICP in a second. If my patient develops a hemorrhage post-brain injury, what's going on with that patient? They have a bleed somewhere. And then along with hemorrhaging, they can also develop hematomas. And what's the difference between a hemorrhage and a hematoma? It's a collection. So the hematoma is a collection of the blood. The patient has had some bleeding and the blood collects in an area. So what happens to the pressure on the brain tissue or within the brain tissue if my patient develops a hemorrhage or a hematoma post-injury? It increases because remember the skull's rigid. It has no room for extra contents or extra volume of contents to come in. So therefore it increases the pressure on that brain tissue. This can be life-threatening simply because there's no room for this blood to pool or this blood to collect. So the skull will not accommodate to this patient. So if I have a hematoma that collects on my skin will stretch. It will bulge to accommodate the hematoma or that blood collection. The skull's not going to do that. The skull's rigid. It's going to stay where it's at. So when that blood pools or collects, that force goes inward onto that brain tissue, okay? The skull won't accommodate, so the brain will have to. Another complication is brain herniation syndrome. So brain herniation syndrome, and that's where the brain itself herniates or shifts. So if I tell you that a patient has a hernia or a herniation, what happens to that area of tissue? What does the tissue do in itself? It bulges. So we have little babies that have umbilical hernias, and what does that umbilicus look like? It will bulge, it lumps out. And that happens also with the brain tissue. So brain herniation syndrome, is where the brain tissue shifts or herniates outwards. So it bulges outwards. If a patient develops brain herniation syndrome, there's about a 60 to 85% mortality rate. So about 60 to 85% mortality rate. So the brain tissue is bulging out. Brain tissue is very sensitive. It's fragile. It doesn't have a lot of, it has elasticity, but it doesn't have a lot of firmness to it, okay? So So when that area bulges out and I have an increased intracranial pressure, what can happen with that area of herniation? It could rupture. Absolutely, it could rupture. So things you want to assess for that patient are going to be pupillary changes. So assess that patient for pupillary changes. And then we have hydrocephalus. What is hydrocephalus? Increased fluid. So an increased fluid volume, or CSF. So an increased volume of cerebrospinal fluid. So it's an increased volume of cerebrospinal fluid, CSF. So two things can cause this. Either there's a lack of reabsorption, so for some reason the body's not reabsorbing that CSF that has been produced, or there's a blockage. So either the body's not absorbing, so it's a lack of reabsorption, or there's a blockage that has occurred. If a patient develops hydrocephalus, which means that the production or the volume of CSF within the brain has increased, or within the skull has increased, it can lead to an increased ICP. So it can lead to an increased ICP or increased intracranial pressure. So hydrocephalus is an increase in the CSF volume, and when it increases, it can lead to an increased ICP.
So with the increased ICP from the hydrocephalus, could they treat that like they do like babies born with hydrocephalus and put a shunt in and route it to their stomach?
It depends. Sometimes if the brain injury is so severe, you can't go in this tissue. So what we can do is, we won't cover this on the test, but you can do burr holes. So you can go in and actually drill holes within the patient's skull, or you can do a craniotomy. And with that, they remove a piece of the skull and allow that fluid to drain, allow the swelling within the brain to kind of go down, and then replace with that patient's on the skull. Okay, all they'll do is they'll cut an area out where the swelling is, and they'll actually insert into the back tissue in the belly and let it thrive there. And then once the swelling and stuff have resolved, they'll go and replace it with the patient's on.
So I'm figuring that was a little higher than what we were going.
Yeah, but give it one more semester and I'll get to that part. Alright, so that's okay. Increased ICP or increased intracranial pressure. So normal ICP is anywhere from 10 to 15. So normal ICP is anywhere from 10 to 15. And there is special monitoring that can be done in your ICU, CCU units that will let you know what the patient's ICP is. So normal is 10 to 15. If I have sustained ICP of greater than 20, that's going to be a pretty poor prognosis in my patient. So sustained ICP of greater than 20 is going to equal a pretty poor prognosis in my patient. So when we look at cranial contents, we have three main things: brain tissue, blood, and CSF. So brain tissue, blood, and CSF. Because the skull is rigid, when either one of those increases, it increases the pressure. It increases that patient's intracranial pressure. So if my brain tissue swells, I have increased pressure. If I have an increased flow or accumulation of blood from my hematoma, I have increased pressure. And then if I have hydrocephalus, or the volume of CSF is increased, it leads to increased pressure. So any of those things can lead to pressure within the brain being greater than what it is. Now, there are things outside of a brain injury that can temporarily increase an ICP. We don't worry about those things unless the patient has like a herniation or an aneurysm. So coughing, sneezing, straining during a bowel movement, pushing during childbirth, vomiting will all increase the ICP temporarily. And that's okay. Because once you can sneeze 3 or 4 times and you stop, it naturally immediately goes back to normal. All right. Now, if that patient has had a brain injury, and let's say they have brain herniation syndrome, and they begin to vomit, is that now safe for that patient? Because that only one vomiting can get to that area of herniation, increase the pressure on it, and actually cause that patient to bleed. Okay. So just be mindful, there are some natural things that can cause it. So straining during the bowel movement can cause it. Therefore, if I have this patient that's had a brain injury, I'm going to give them some type of Colace or some type of laxative. So therefore, when they have a bowel movement, they're not straining during that bowel movement, because we know those things can increase that pressure. Do I worry about ICP being elevated or more dangerous in elevation in a closed or open injury, or is it dependent on the patient?
Closed.
Closed? And why is that?
If it's open, you have room for the tissue to swell or
You have some room to accommodate, absolutely. So if I have a closed head injury or a closed brain injury, I have no room for accommodation. I only need the volume that I need, and that's it. If I have it open, at least I have some space, not a lot, but at least some space for this increased ICP or this increased production to flow to accommodate that pressure. Unfortunately, with those patients, I also have a risk of infection and such, so it's kind of like which one, which you rather have. Another thing to consider is when one component increases, something else has got to decrease, okay? So if the brain tissue swells and that takes up that space, that volume within the skull, I'm going to get decreased blood flow and decreased CSF, okay? That's naturally going to occur. So as one increases, the other components will naturally decrease. So if the brain tissue itself swells, I'm going to get decreased blood flow, decreased CSF, and that just leads to a whole other multitude of problems. So one thing that these patients can develop is called Cushing's triad. So Cushing's triad. Now it's pretty indicative of the patient deteriorating. Unfortunately, it doesn't occur until late. Okay, so it's a pretty good indication of the patient deteriorating. Unfortunately, it doesn't occur until late. With these patients, they'll have high blood pressure, so they have hypertension, decreased heart rate, decreased respiratory rate, and an increased pulse pressure. So elevated blood pressure or elevated systolic, a decreased heart rate, decreased respiratory rate, and a widening pulse pressure. That just means there's a bigger gap at each reading between my systolic and diastolic, okay? Now, my numbers could still be somewhat normal, but widening, so don't just look at what is the systolic and diastolic, oh, that looks good. Pay attention to there's beginning to be a larger gap in between those numbers at each reading, okay? So we looked at some common causes of traumatic brain injuries. I know we talked earlier about car wrecks can cause it, football injuries. The main things we're going to see, the primary causes actually are going to be falls and motor vehicle wrecks or car wrecks, okay? So falls and motor vehicle wrecks are going to be the most common causes. Falls are going to occur more often in what population of patients? Older people. And that may be because they have a change in cognition, they have changes in their depth perception, they may have an unsteady gait. That's the reason we don't like to get drugs and stuff out of the way. Or it could be a side effect of a medication that patient's taking. The other issue that we have with older adults is a lot of them are on blood thinners. So if I have a fall that leads and that patient's taking food in, now I'm really in a bind, okay? So a lot of those patients take blood thinners. Males versus females, who do you think is gonna have more traumatic brain injury?
Males.
Males.
What?
Young
Young
males.
Young
Our guys. And why is that? What do guys like to participate in?
They're risky behaviors.
Risk-taking sports, and then we have more guys that tend to join the military. We know, depending on your job within the military, that can lead to an increased occurrence also. So definitely male versus female. Multiple things can cause a TBI or traumatic brain injury, but most commonly car wrecks and falls are going to be the two more common, and then falls more commonly in our older adults. About 1.7 million traumatic brain injuries are sustained annually just in the United States alone. So when this patient comes in, and when they come to the hospital, I don't know if they have a TBI or not. All I know is EMS or a family member, somebody who's brought this patient in. So what kind of history would I like to get from that patient? What are some things I would like to know?
What's their baseline?
What happened? Did they lose consciousness? What's their baseline? If they lost consciousness, for how long? Did they lose consciousness? If they're on blood thinners? Yep, absolutely. If that patient's on blood thinners, I would like to know that. Let's say, will the patient always be able to recall what happened? No. Sometimes the injury is too severe for the patient to let me know what's happening. So, were there any bystanders or witnesses that can let me know what happened? Sometimes the patient walks in and they're talking, they're awake, like oriented, but they may have a period of amnesia associated with the event itself, okay? Something else I want to know is, was there any alcohol on board or any illicit drugs on board, okay? So any alcohol or drugs on board. I would also like to know if the patient had any seizure activity immediately following the injury. So we think about level of consciousness a lot, and it's very important, but also was there any seizure activity associated with it. When we do our physical assessment, we want to look at our airway and breathing pattern. So looking at start with ABCs, okay? So start with ABCs. Most stable patient, if it's a mild traumatic brain injury, do they need any supplemental O2? They should be okay. But if I have more of a moderate or severe injury, then I may need some type of supplemental O2. I may need an artificial airway. And then sometimes the injury is severe enough that we actually use life support or mechanical ventilation on those patients, okay? When we look at spine precautions, what things need to be on that patient or in place when they arrive? A seat collar and what else? A long backboard. So a seat collar and a long backboard. Let's say if the kid's playing football and mama just grabs the kid and brings him to the ER, am I still going to put them on the seat collar? At that point, would I necessarily place on the backboard? No, but definitely a seat collar, okay? So if you're working in the ER and you're triage and they say, oh, he got knocked out at the game, but I didn't pay on Metro, I didn't want to pay that bill, so I just brought them off. Go ahead and put them in the collar, okay? Who can remove a backboard from a patient? Physicians, okay? So my physician's assessment gives me the go-ahead to take that patient off that backboard. What do I have to have done before I can remove the seat collar?
Just a physician actually comes in and does that assessment.
Yep. What else? Some type of scanning, okay? So at the bedside, I want to get the board out from that patient as quickly as I can, okay? They hurt. It's like laying on the ground. It hurts, okay? So as quickly as I can, I want to get that board from under that patient. My physician can come in and clear that patient, and we can remove the board, okay? That collar stays in place until your scan results come back. So that collar stays in place until the scan results come back. Y'all know a lot of times with injuries, patients are kind of like in shock, and they don't always hurt. So what I'm looking for when I do that assessment, it's like some tenderness, because I know if it's tenderness, it could be an injury there. So if they're in shock about what just happened, and we may be palpating and feeling and stuff, I mean, so no, it's fine, it's fine, it's fine. For the whole time, they couldn't have a spinal injury, okay? So that C collar stays on until the CT or MRI results are back. It's not out of the realm of possibility that you won't transport a patient into a higher level of care with the collar in place, okay? If they actually have an injury. So sometimes it doesn't come off until the surgeon has seen it or until they're actually going into some type of neurosurgery. So vital signs, we talked about Fisher's triad earlier. It's pretty bad sign of poor prognosis for these patients. Low heart rate, elevated blood pressure, widening pulse pressure, and irregular respirations, decreased respiratory rate. Unfortunately, it's a pretty late sign that occurs. So unfortunately, it's a pretty late sign that occurs. Initially, when this patient comes into the facility, the first stop's typically going to be your ER setting. How often would you like vital signs in that patient? About every 15 minutes. About every 15 minutes, okay? And now once we start ruling out injuries and stuff and they're stabilized, we can bump up the frequency of it. But initially, every 15 minutes. Because I want to detect any changes as quickly as they occur. So if I have every 2 or 3, 4 hours, that patient could decline a whole lot in between that time period, okay? When you go in to do your assessment, of course you have your initial assessment, but pretty frequently you're going to be going in and assess the level of consciousness, hand grips for symmetry. You're going to be assessing pupillary changes, okay? That's not a one and done. If my patient has a brain injury and the tissue doesn't swell until 30 minutes later, it may be that 30 minutes later before I get pupillary changes and changes in level of consciousness and stuff. So it's going to be pretty frequent physical assessment and vital sign assessments on these patients because we know all changes won't occur when they present to the ER. All changes won't be evident when they present to the ER. So what is your Glasgow coma scale? What does that let you know? How alert or unconscious the patient is. So it's a pretty simple way to detect the patient's neurostatus. So it's a pretty quick and simple way to detect a patient's neurostatus. Do you want high numbers or low numbers on your GCS? High. The higher the better. So the higher the better. So I want higher numbers because the higher the score is, the better it is for that patient. Their score can range anywhere from 3 to 15. So it can range anywhere from 3 to 15. And if it gets to 8 or less, I'm concerned. So if we get to a GCS of 8 or less, I become concerned. But also any dropping points of 2 is also concerned, okay? So if I start out at a GCS of 15 and I come back and I'm at 12, that's still concerning. I haven't made it to 8, but obviously I'm having a decline if that number's trending down, okay? You're going to assess eye opening, whether it's spontaneous to sound to pain or never, so they just don't open their eyes at all. Their motor response to their obey command, localized pain, normal flexion, abnormal flexion, extension, or none. And then also their verbal response. Are they oriented? And that's confused conversation, okay? So if a patient comes in with a brain injury and I say, tell me person, place, and time, they may not be able to recall that today's Thursday, October 19th, okay? Because they just have an injury. That doesn't mean they're confused, all right? They're still oriented. They can tell you, my name's Bob, I'm at the hospital, and it's the fall. That, you know what I'm saying? That's oriented, okay? What you're looking for is confused conversation. You ask them a question, they give you an answer that's not related to what's going on, okay? Inappropriate words incomprehensible sounds, that just means you ask the patient something, and it's just a whole lot of mumbling, groaning, and that's it. But they don't even make an effort to actually speak to you, and then of course, so it can range from 3 to 15, the higher the better. 8 or less is concerning, and any dropping points of 2 is also concerning. So I don't have to get to 8 before I call that physician. If I do my initial assessment and my follow-up is 2 or more or less, I'm still going to go ahead and make that call because I'm going to catch some changes sooner than later. Their level of consciousness, what am I looking for then? Are they alert? Okay. Do I want the patient awake the entire time, or do I want them to be aroused for it? Either one. Awake the whole time. Okay. Let's say they kind of doze off a little bit, but as soon as I walk in the room, they wake up. Can we live with that? We can be all right with that. Let's say if I walk in the room and I'm moving stuff around and I get ready to start an IV, I'm putting tourniquets on and splints and all that, and they aren't doing a daggone thing. Am I concerned? Now we got a problem, okay? So any decrease or changes in level of consciousness is a pretty good indication that your patient's deteriorating. So any decrease or changes in level of consciousness is a pretty good indication that your patient's deteriorating. What pupillary changes may we see? Maybe pinpoint or dilate, depending on what area of the brain the injury is in. Okay, that's not something you all have to know. All you need to know is that you got some pupillary changes. Okay, so it could be pinpoint, could be dilated and fixed. Really depends on the area of the brain that the injury is in. Will the pupils always have bilateral changes? No. Okay, so depending on the type of injury the patient has, I could have unilateral changes. I want to also assess the size of the pupil. I also want to assess the size of the pupil. And if I can, I want to get the patient to follow my fingers, let me know how many fingers I'm holding up, give them my badge, see if they can read that, just to kind of get an idea of their vision in general, okay? Motor response. What am I going to ask this patient to do? Squeeze. And then after they squeeze, what I want them to do? Make sure they release on command, okay? If you put your hand in a baby's hand, what's that baby going to do? Does that mean they're obeying command? That's just a reflex, okay? So I want to squeeze, but sometimes that's just a reflex. So if I say release my hands, that lets me know that patient can follow my commands, okay? What else would I like to know as far as motor response? Right, you'll have changes on both sides, absolutely. You'll have changes on both sides. Weakness on both sides is better than weakness on one, okay? So do I have bilateral changes? Cerebrospinal fluid, what does it look like? It's clear. If it's going to leak, what 2 sites may I see it leak from? Nose and ears. Nose and ears, okay? So if it's going to leak, it's going to leak from the nose and the ears. Looking at it, can I tell that it's CSF? Also, what kind of test can you do to determine? You do the halo test, okay? You do the halo test, and that's going to be more specialized areas that do that, but it checks for glucose within the CSF. All right. Scalp assessment. What would I like? Let's say the patient comes in, they've been in a car wreck. What I want to look for within the scalp itself. Redness, tenderness, lacerations, any open areas, any bleeding. Make sure you're assessing all those things, okay? We try not to cut people's hair, but sometimes we have to clip a little bit to get down to it so we can actually see what's going on with that patient. But palpate gently. If that patient has any thickness or tender spots, they need to let us know. But any fractures, hematomas, bruising, lacerations, any changes, anything that's not intact and the normal, we need to make that physician aware of. So if a patient has a mild traumatic brain injury, what do we brain injury, we're gonna monitor for a little while, and then that patient can typically go home. What if they have a more moderate injury? Oh, maybe
Observation.
we may leave them in the ER for a little while longer. It really depends on the severity of it and how they're doing. And then also other comorbidities, are they on blood thinners, things like that. If they have to be admitted, we can usually put them on a medical floor, okay, because they don't need as much monitoring. But if I have a severe injury, where's that patient go? Some type of ICU unit or intensive care unit. While that patient's either in the ER, medical floor, ICU, doesn't matter. What am I going to continue to do and assess until they are on the way out of it? Vital signs, LOC, ABCs, intake and output. So that's not a one and done. I'm going to continue to do that until that patient's on the way out the door, okay? Now, I'm going to do it more frequently with my severe patients than my moderate and mild, but nonetheless, it's not a once and done type thing. It continues until the patient's discharged. Preventing and detecting secondary brain injury. Some things we want to do is monitor the patient's blood pressure or control the patient's blood pressure. Because if the blood pressure drops too low, what do I have? Decreased perfusion. And if the pressure goes too high, then I have what? What happens to the brain tissue? It increases the injury there. So either way, I got a problem, okay? So we need to maintain the blood pressure. These patients can have dysrhythmias, so we want to make sure we do some type of cardiac monitoring. So these patients can have dysrhythmias, so we need to do some type of cardiac monitoring. And another thing we worry about is fever. So these patients can also have fever. Now, depending on the cause of the fever, sometimes it's an inflammatory response, okay? With that patient, Tylenol is going to be probably going to take care of. With other patients, it's more of a biochemical response from the injury itself. So with Tylenol, fix that patient. It wouldn't. So with that patient, we're going to do a therapeutic hypothermia. We're going to intentionally cool the body down. And in doing that, we decrease the metabolism to the brain. So we just give the brain a little opportunity to not work so hard, okay? So we do therapeutic hypothermia, where we intentionally cool the patient, and that just gives the brain time to recover because we decrease its workload. With that patient, we'll have a temperature range of about 89.6 to 93.2 degrees, okay? So if you saw that in any other patient, you'd be concerned that would be your goal for this patient. That only lasts about 1 to 2 days, and then we're going to slowly re-warm the patient. So the therapeutic hypothermia only lasts 1 to 2 days, up to 48 hours. And once that's done, we'll slowly re-warm the patient. If we re-warm the patient too rapidly, then we get into a whole other set of dysrhythmias, okay? So if you go from an 89-degree patient to a 100-degree patient, you don't have a whole lot of problems. So it is a control or slow re-warming. So sometimes with our severe brain injury patients, we do worry that the injury is so severe that that patient does not survive. So then we have to look at determining brain death, okay? There's not one certain way or manner to do it. Depending on where you're working at, the protocol will differ a little bit. Depending on whether you have an ER doctor or an ICU doctor, that may do it a little bit differently, okay? But 4 things we for sure want to look at is that the patient has had some type of coma and it's of a known cause. We know why this patient went into a coma. So it's a coma of known cause, which means we know why it occurred. The patient has to have a normal or near normal core body temp. So they have to have a normal or near normal core body temp. Because if it's too high or too low otherwise, then something else could be causing this changing LOC and things like that. They have to have a normal systolic pressure. So normal systolic blood pressure, and at least one neuro exam has to be done. So at least one neuro exam has to be done. Imaging and scans are not required, but they do help support that diagnosis of brain death, okay? So imaging and scans are not required, but they do help support that diagnosis of brain death.